We don't think of ketamine as a treat and release. It's not like an urgent care where you see somebody and they go home. It's definitely not like an ER where hopefully you don't see them again if you did your job. This is a real long-term process.
3, 2, 1. Liftoff.
Welcome to the Ketamine Startup Podcast. This is where we talk about how to start up a ketamine infusion clinic, market it, and more. In this episode, Sam interviews Dr. Nico Grundmann, emergency medicine physician, co-founder, and CEO of Ember Health. Dr. Grundmann shares his journey from training and working in the ER to building a 5-location ketamine practice across New York. He discusses the significant mindset shifts required when moving from shift work to longitudinal care, the clinical evidence behind their 4-infusion protocol, and how they've scaled while maintaining evidence-based standards. We cover the difference between medicine in the ER and ketamine therapy practice, clinical protocols backed by real outcome data, and Dr. Grundmann's strategy for influencing healthcare policy through demonstrable results. We learned a lot in this episode and hope you do too. Now let's jump into the episode.
Welcome back to the Ketamine Startup Podcast. I am so thrilled to have Dr. Nico Grundmann here. He is a background in emergency medicine and the founder of Ember Health in New York. So he's going to tell us a lot more and share the background. But first off, just welcome. It's an honor to have you here, Nico.
Really appreciate it, Sam. It's my absolute pleasure to be here.
So tell us your background, because I was doing a little bit of research. You not only have a medical degree, but you also have an MBA. So let's rewind back even before the ketamine startup happened.
Yeah, so I can take the story back really far into my childhood because it does play in all of this. So my parents both did international public health. And I spent a lot of my early childhood overseas, actually in Africa, in Rwanda for a number of years, in Morocco for a couple of years. And then they went to Cambodia, and I was in and out of Southeast Asia for about a decade as I got to be a young adult. I bring it up in that my mental model of the world was very much this public health mental model. I listened to my parents talk about it at dinner all the time. I thought after college I was going to do that as a career. So I actually spent a number of years working with groups like the Harvard AIDS Institute, doing work with ministries of health in sub-Saharan Africa on their HIV programs, cost effectiveness analysis of different retroviral drugs, kind of really policy level systems type work. And in doing that, realized I really liked the high level thinking, but also really liked clinical care and actually seeing things happen and change. And so made the decision to go back to med school, focus on medicine. And that is what eventually got me into EM, where emergency medicine was just this really nice mix of broad knowledge of the medical field about how to help folks. I really liked the ability to have a quick impact for people. And so focused in on EM as a career, came out to Kings County here in New York in my residency. And it was as an EM doc that I first got involved with ketamine. We used it all the time at County. Literally a couple times a shift, we'd reach for it for conscious sedation or anesthesia. I did a kind of a fellowship type structure where I would go to really rural EM facilities to be like the only doc on coverage for 24 hours in West Virginia and Indianapolis, and started using that as a way to kind of get a sense of the U.S. healthcare system and how ERs across the country were working. As you can tell by the fact that I'm now running something completely different over years, all of that was in this lens of how could I combine the things I liked clinically about direct patient care with the things that I liked about systems and policy. And that's also why I went after the MBA. So when I was in medical school, Stanford had a unique opportunity where they let you do both a medical degree and combine it with going to Stanford Business School. And that seemed like a really fortuitous combination, one where I figured I'd be able to use that knowledge eventually, even though I wasn't at the time 100% sure how it was going to play out. And so the dual degree kind of influenced me as I started to think of what else I might be interested in doing. Our practice's founding is very much that kind of merger of things. So I was in West Virginia. I had seen some data on ketamine for depression, but had a slow night. And so really dove into what the literature showed. I'm kind of an evidence medicine-based guy, and was a little blown away at how much had been published even back in 2018 on this topic. That led me literally calling my wife in the morning and saying, hey, this sounds like a thing that is missing in the country at this moment, that there's this really clear clinical outcome that's in these publications and in this academic world, but there aren't really great options for this that we're seeing when we look around. She was a management consultant at the time. She brought me into her office. We did whiteboarding sessions about like what this could look like. We really, from that day zero, had this idea of kind of start in one place, and I can share more about that, and then take it so that we could affect the national conversation as a goal. And the seeds of that are what became our practice. We opened a pilot site in 2018. Basically, 2019 is when we saw our first patient. We ran the pilot site for almost 2 years. Realized it was working both in how the patients were doing. They were doing really well. We were seeing like actual real world outcomes matching that clinical data of the academic world. And we could make a business operation out of it. We could make something that would like pay people salaries for the nurses, and the docs could afford to do the work and not have to juggle from an EM career in this at the same time. At this point, we have 5 offices here in New York City. So we just kind of, once we worked in the pilot, we started opening sites and expanding. And we've got a team of about 30 total across the practice. And we've treated about 2,200 something patients at this point. So 36,000 infusions, really grown it quite considerably in the couple of years we've been doing this now.
Kudos to you, Nico. That's really impressive. I mean, starting from that one location and then expanding it to 5 clinical sites. I mean, that's wild. Let's like rewind back before we dive into like the what currently exists. So it's 2018. You've done the deep dive, and you're like, wow, this is really fascinating. You're working that shift, and you have some free time. What was that pivotal moment where you're like, this is it. This is actually what I'm gonna do, 'cause it's a bit of a risk, as you know, like, when we're working EM, it's a super stable career. We know we're gonna get our monthly paycheck and salary, et cetera, as long as you work
Yeah,
on the number of shifts.
I remember that.
So what was that pivotal moment?
Um, it was less of a kind of leap all in than you might expect. So that was part of the pilot aspect of this, is that when we sat down and whiteboarded it, when my wife brought me in, I should mention Tiffany, my wife, is the co-founder of the practice. So we're both on this full time. We both work together. We're a bit of a unique husband and wife couple in that. So she is full time on this as well as me at this point, and has been so since 2020. But that first whiteboarding session really made a couple of things clear for us. I mean, we could see that there was a mismatch in skills for this type of work, that the physicians, for the most part, that are really comfortable with intravenous infusions of ketamine, with conscious sedation, with anesthesia, medical monitoring, like that's a type of doctor, EM, anesthesia, ICU, that is not the same type of doctor that normally treats depression. Psychiatrists are really good at what they do. They're really good at longitudinal care management, really good at assessment. They don't tend to be the most comfortable with IVs. They don't tend to be the most comfortable with conscious sedation, monitoring, adverse events, etc. Yet their patients were the ones who really needed this. And so our vision for Ember was this bridge between disciplines, where we'd take a bit of like a augmentation of people's existing panels and existing patient panels. So the psychiatrist would still manage their patient. We'd help get access to ketamine through our services. We'd have to do a lot to make sure that that happened with good evidence about how to run the protocols, with good one-to-one patient care and patient experience side of things. And in our case, with care collaboration, we only treat patients who have a larger outside mental health care team. I feel very strongly that that's really the best way to ensure that this is a net help for a person, is that it's part of a larger care plan. And at the same time, expecting psychiatrists to retrain or expecting them to get additional comfort with the things that make this work safely also didn't seem like a national thing that could be scaled or a national thing that could be sustained. There are already a shortage of psychiatrists in the country, and asking them to do even more just because this works well didn't seem like it was going to be possible when you talk about the number of patients that need this.
Yeah, so as you opened, and, I'm really glad you did the kind of the test site or the pilot site. What with that first clinic, were was your model where you were actually the administering clinician, or did you already initially like, "Hey, we're just gonna hire, other doctors and other staff," or was it mainly you, the first one?
No, we had this idea, and we could kind of make it work on a whiteboard, but we had no idea if it was going to be a real thing. And so I spent almost 2 years where I was still taking EM shifts, still getting that as our stable paycheck. My wife was also working. I incorporated the company. We worked with lawyers to make sure it was done kind of correctly, given all the corporate practice of medicine stuff in the US. And then we literally just started knocking on doors. I actually would go like around our neighborhood. We're in Brooklyn Heights. It's a really beautiful place to live, and there are a lot of mental health providers in our region. And I'd literally just introduce myself. I'd have like a couple of papers with me that I printed saying that like this is real. This is not something we're making up. But it really was like door to door grassroots raising awareness about this. And I'd talk to folks if they had patients that maybe could benefit. We'd set up a consultation. It took, I don't know, a year until we hired our first nurse. It was just me as the only clinician. My wife would occasionally man the front desk, which felt very silly considering her skills. And then over time, as the pilot started to see more and more patients, we brought in a nurse, we brought in an office administrator. The pandemic hit, we can talk about that. And as it became clear that no, there was both a clinical outcome, but also you could make an operational engine that actually worked. You could structure visits kind of cleanly in a way that you could actually predict what volumes would look like over time, et cetera. Only once we really had that kind of borne out over, again, about a 2-year period, did we feel comfortable saying, no, 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 okay, this is it. Let's lean in all in on this. I stepped down from EM. My son was born right then too. So we had this kind of family life of the practice and my son being close to the same age. My wife stepped down and became full-time at Ember in March of 2020, right before the pandemic. And that was really when we decided to kind of go all in and say that, hey, no, this isn't just kind of a blind faith leap. We've proven it enough that we feel comfortable growing from here.
What did your colleagues think in the EM? And I'm just curious about your perspective because I did a similar thing where, I was working part-time in the ER and then part-time in the clinic during the first couple years. Like, what were your colleagues saying? Like, hey, Nico, it's a great idea? Or were they like, you're out of your mind? What was the feedback you were getting initially?
Really positive. And actually, of our current team, 2 of our 5 doctors came from the same residency program I did. And our original first doc, who's not with us anymore, but she was also from my same EM class, and she actually joined as our first hire. So Kings County has been a great resource for us, where it's an amazingly strong educational program. Just residents, I feel really comfortable with nuts to bolts everything EM, and they're very open about kind of novel ideas. They're really big believers in evidence-based medicine. And so it was a really easy group to talk to about this. Most of my classmates had also already known that I had this kind of duality of clinical career and interest in systems stuff. I used to give lectures in residency about kind of residents' financial planning and how to think about retirement as a resident. And so that lens of not just being a pure clinician was one that most of my colleagues had already heard of. And they weren't really surprised when I went and did this.
That's awesome. I actually interviewed at SUNY Downstate, and this is back in what year was it? 2007, 2008. So it might have been a couple years.
That's right. We would have been, if that was for your residency, that would have been about 4 years before me. I was,
Yeah, and I remember meeting, and I don't know if he was the program director back then or when you were in it, but Christopher Doty,
yeah, yeah,
Dr. Chris Doty.
yep.
And I remember distinctly my interview with him. This is like a side note, but I was really impressed because I said, "What's your mission and goal? What's your goal from this EM residency program?" And he said something really interesting. He said, "I want to create monsters in emergency medicine."
Yeah, clinical monsters was a big catchphrase for our residency program. They really wanted people who could be EM doctors, go anywhere, do anything, feel comfortable in any situation. So our residency would go man the finish line tent at the New York City Marathon. We'd like ICU tent, which was described as the largest mass casualty event in the country, the largest planned mass casualty event in the country each year. We had just a really cool group of people who had a really diverse interest in international health, admin, ultrasound. Actually, one of our docs here at Ember was running the ultrasound division at Kings County for a bit before he joined with us. And it was just an open-minded group of individuals, which was really helpful.
Yeah, it sounds like there's a lot of support from the program and then a lot of colleagues who trust you and who want to work with you. So for you, I know a lot of the ketamine clinic owners and specialists and people in this space, they usually, I would say the majority, like it's usually a one clinic operation, right? Like the one place in Seattle or the one place in Denver. And there's a handful of doctors who have multiple sites. So, maybe it's your systems thinking in the background, but what's your thoughts or advice for someone who wants to go from one clinic and, work for themselves essentially? So they're creating, they're a clinic owner slash operator to like, hey, the next level, which is, I'm not only running, like seeing patients, but I'm actually hiring other clinicians.
I don't know if everybody would want to do that. It's actually a pretty massive change in what you spend your day to day doing. In my case, it was a goal. We knew that we could have a site treat a couple hundred, maybe. Our sites can see like 300-ish patients per site as a steady carrying capacity. And that is really meaningful because those 300 people's lives are deeply affected by this and do well. And all our patients are chronically suicidal. Half of our patients have had a suicidal thought in the 2 weeks before they start care with us. So it's a meaningful thing to be able to treat those people at a single location. And our vision for this was, well, we need to do that to prove it out, but we also need to do that so that once it is proven out, you can actually address the mental health issues across the country more broadly. And so from the very beginning, Tiffany, my wife, and I, we were talking about like, what would setting a gold standard of care look like? What would collecting enough evidence that you can convince an insurance company to pay for this look like? What would be the policy things that need to fall into place? And how can we actually help build towards that so that this isn't just something that we're doing ourselves for the people that we can interact with, but we can actually kind of change these national narratives and conversations? And for us, one of the realities of that was, well, we had to prove it out at big numbers of people, both in terms of number of patients treated to be able to have enough data to go to an insurance company and say, hey, for these 2,000, 10,000, whatever it is, here's how this actually performs in the real world. Because you know this, but to say it for the audience, ketamine is generic. Racemic ketamine has been off patent for 25 years. There's no pharma backing to get the FDA to change it. There's no insurance company who's advocating to Blue Cross Blue Shield to cover this. And so if it's going to change from a reimbursement perspective and an access, given that finances are the biggest barrier to access for ketamine, you need groups and somebody to be getting and collecting that information and then using that information. And that was really, those were the core reasons why we opened more sites. It's that, okay, it was very different than clinical practice. I still see patients, but only when I'm covering for other doctors. It's a totally different thing to spend your day to day managing people and managing other providers, getting into the kind of contract work with insurance companies and all of that. I don't know if everybody likes doing that. So I don't know if that's always the right goal for people who are trying to build something like this. But as long as you feel comfortable with the kind of shift into administration, shift into kind of systems building and protocols and all those things, then it's really fun. I find joy in this. But it's definitely a shift. It's definitely a mindset change from the kind of direct provision of care.
Hey, listeners, this is Kim, and I just want to acknowledge that you're here for a reason. Maybe you're stuck in a cycle of long shifts, feeling a little burnt out, and wondering if there's any other way to practice medicine, especially on your own terms. We've been there, and that's exactly why we created this free checklist, your step-by-step roadmap to starting a ketamine clinic without those costly mistakes. Grab your copy now at www.ketaminestartup.com/checklist. It's completely free because we want you to succeed, not struggle. And hey, if you're driving or mid-workout, don't sweat it. Just check out the show notes for the link when you're ready. And again, that's www.ketaminestartup.com/checklist. Now let's get back to the episode.
Yeah, you are absolutely right. It does require kind of ascending in a way or just having a different perspective because being, in the pit or in the clinic versus working on it, it does require something different. And in a way, it almost seems like you were meant to be doing this. I mean, that your background had kind of set that foundation for you to do what you're doing now because you were even before you were thinking about systems thinking and protocols and all of that.
Well, that was exactly it. Is that when I had that night in West Virginia where the data was coming in, and then when we did whiteboard it, even from that very first whiteboard, we were talking about, okay, what would need to be true to lean all in, and the pilot site was our answer to that. And then it would be, okay, what would the next couple of years look like in terms of what we need to accomplish before we try to think even bigger? And for us, that was there has to be more evidence published about this. And so we set about collecting data ourselves. We do a lot of longitudinal PHQ-9 monitoring, so we get a lot of quantitative outcome tracking of our own patients with their permission. We knew that we had to treat a certain number of people to be able to have information that would then be valid. And hence, we needed a certain degree of scale, a certain number of providers on our team, a certain number of offices open. And we're there. I mean, it's not done, but we're publishing our data with MGB. So we have a data collaboration with Harvard and Brigham. We're hoping to put out like 6, 7, 8 papers this year about the long-term real-world outcomes of ketamine. There's been a ton in the short term, not as much as we would hope for in the long term. With ASKP, we're doing a lot of work on advocacy for getting, hopefully, Medicare to pay for this in the Northeast, looking at Medicaid in New York City, talking to employers and stop-loss insurance brokers to try to get this covered under employee health benefits. But we couldn't have any of those conversations. We couldn't do any of that work unless we had this kind of foundation laid across the practice. And that was really from that early days, kind of our vision of era 1, era 2, where things go from there.
And how was that coming with the insurance aspect? Because you did mention, you've collected the data, and I think that's one of the pieces that insurance companies want to see because of that publication. And feel free to share or not share, so I'll leave it up to you. But are you able to help patients get insurance coverage, or is it more of the super bill model, at least at your office? Because I've seen different ways that clinicians have done it.
Yeah, it's definitely a work in progress. This work is slow. 2018, no one would even have a conversation about this from an insurance coverage perspective. And then that's thankfully already changed a lot, not just from our efforts, but from national efforts on this. You might know this, but there are 5 states where Medicaid pays for ketamine across the country. Blue Cross Blue Shield covers ketamine in a couple states at this point, IV ketamine for depression specifically. The VA in 2022 started covering IV ketamine in, I think, 22 states, if I remember correctly. So there's already been movement on it. For New York State, it's still out of network only. So in our jurisdiction, we do super bills. We actually have built a pretty big back-end system that actually submits the super bills for our patients, helps navigate the out-of-network reimbursement process for the clients that we work with. So we see something like 75% of our patients get 70% of their visit back through an enormous amount of effort on our team's part, but it really makes a crucial difference to being able to afford this over time. And there's some exciting kind of stuff on the horizon where once our data is published, we have this process ready to submit to the local CMS group up here in the Northeast. That's a 2-year thing that we go through with them. So it's not tomorrow, but it is happening. And in the meantime, once those publications come out, we can do more advocacy work. We can do more kind of going to insurance groups and talking to them and saying, hey, while this is cooking, are you willing to give this a try, et cetera. But these are slow processes that take a lot of time, and hence kind of a patient game. Have to have the current framework for the current patients and that be a viable thing for them and a supportive thing for them. And with this vision of what this could turn into or what the country could be benefited from in terms of access for this over time.
Yeah, it's definitely a slow game. It takes a lot of patience. Sometimes, at least for me, I don't have that patience. Like being in the emergency department and having that background, I'm like, yep, I want to get those lab results in the next X number of minutes. So, thank you for doing that work because in a way, when you do it for your office and for Ember Health, then that allows other clinicians to say, hey, this is happening over there. Kind of,
And a lot of the frameworks we're working on here, remember, they're not Ember specific. So if CMS does say yes, that's not just to our practice, that's to the Northeast. I very much of the mental model that a rising tide raises all ships as a kind of a philosophy. And these aren't the policy level stuff we're working on is going to benefit whoever has access to it in those jurisdictions. Individual insurance contracts, yeah, those are with us. Those are a pain. But those are based off of the body of published evidence, the kind of evidence-based outcomes, the clinical standard guidelines, et cetera, et cetera. And those all have to be collaborations. Those can't be a single group pushing for those, or it's never enough.
Got it. So first the CMS and then the private health insurers will kind of follow suit once CMS approves of it.
It's one of the
And that's one of the hopes. And what's interesting though is, like the VA, for example, they cover IV ketamine. It's in their standard clinical guidelines for treatment-resistant depression, and to me, I'm not a policy guy, but I think, well, the VA is covering it. It's not technically CMS. I mean, they're two separate
Yeah.
departments or organizations, but it's like, all right, you have already one governmental body authorizing and covering it at the VA, for example. So why doesn't CMS get on board, right? Have you thought about this?
Uh, yes, I'm laughing because nothing is ever that straightforward. And the different agencies, the different groups are just different entities. Um, Even for Medicare, Medicaid, what Medicare does isn't necessarily what Medicaid does. Even for Medicare, they're actually jurisdictional. So Medicare is run by, I forget what MAC stands for, but there's these groups that run Medicare services, and there's a little over a dozen of them across the country. So if the Northeast says yes to ketamine for depression, that doesn't mean Florida does. That doesn't mean California does. You actually have to go to each jurisdiction and make the arguments to that local body differently. US healthcare is just crazy complicated. And so these are incremental changes in incremental regions that can make a
Yeah.
difference. But it's not a trigger where all of a sudden one day we all wake up and everything is suddenly covered. That even if that were true at the federal level, you then got to go to the insurance company and negotiate that insurance contract, which is distinct from federal coverage, et cetera.
Well, I'm really glad we have your bigger perspective and the kind of the systems thinking. So thanks for that. What what do you tell So when you hire an emergency physician or a clinician, someone who's used to working in the ER, and like for me, I noticed that when I was doing both, like I have to like shift gears. So sometimes when I'm working in the ER, I'm in fifth gear, I'm cruising, I'm seeing a ton of patients. But at the clinic, when I'm seeing patients there, I have to really slow down. So what advice do you give to a clinician that you're going to hire and say, hey, this is what's different about the way we do it versus in the emergency department?
Yeah, there's in some ways EM physicians, anesthesiologists, they're really good for this work in that they have a core set of skills. And in some ways, it's actually a little bit of a mismatch for them too. It's the same way that a psychiatrist needs retraining about some things to do this. So does an EM provider. So does an anesthesiologist or an ICU doc. The biggest things that we concentrate on for the docs who join our team, some of them are just like normal life. Like, hey, this is Monday through Friday. This is not shift work. And that is different. You in some ways you actually kind of are on call. It's not that your patient's going to text you at midnight and you're responsible for that. We make really clear that we're part of a larger team. The psychiatrist is still there, et cetera. But this isn't a role where you clock out and you're done. That's a really big mental model shift for a lot of docs. EM, you finish your shift, somebody else comes in and they're responsible, and you get to go home. With this work, you have the people you take care of. They're longitudinal relationships. You get to really know people. That has enormous value and feels just really nice to be able to kind of see somebody progress from having depression to being super functional. We get cards from people who have their weddings after treatment, who kind of are able to rebuild their lives and kind of reclaim who they used to be prior to their depression. And seeing that is just a real privilege. And it comes with the knowledge that, like, you're going to see them in the highs and the lows, and they're going to reach out to you and talk to you in a way that with EM is just really different. So, as kind of core things that we go over with our docs when we think about who's a good fit, it's, do you like long term relationships and longitudinal care management? That's pretty different than EM. Do you like a fixed schedule? And that has its real perks. It also is really different than docs who've been working shift work, who work overnight, but then have Thursday off to go do their laundry or whatever it might be. Like, that's a pretty big change for a lot of folks. Panel management is like a normal thing in medicine, but it's not a normal thing for EM docs. And so understanding not just the relational components of long-term care, but also like how to help somebody as they have a hiccup, how to help coach somebody like, yeah, that is something in your life that is really sad. And then sometimes that sad emotion is warranted. Like, that's not necessarily depression returning. That's an appropriate human emotion for a difficult thing. That might not be the time to come back for ketamine. That might be the time to work with your therapist, and here's how we can kind of help coordinate that call, et cetera. Care coordination is a big one. I'd say our docs probably spend 30-40% of their day to day on care coordination, talking to psychiatrists, talking to therapists. That's a really big part of how we practice at Ember. You do consultations in the ER, but you don't have kind of ongoing relations with the psychiatrist on a day-to-day basis. And you definitely don't have the talking about the same patient for 3, 6 months, a year, 2 years, etc. It's just a very different way of practicing. For the right individual, it checks all the boxes. The folks who are really happy on our team are the ones who were looking for that transition. We're missing the longitudinal care. We're missing the patient relations. Still like the thrill of procedures and IVs and monitoring, but also really value those getting to know somebody, getting gifts from somebody because you actually made a difference in their life, seeing quick changes, but then also baking that into the long-term process for these folks. We don't think of ketamine as a treat and release. It's not like an urgent care where you see somebody and they go home. It's definitely not like an ER where hopefully you don't see them again if you did your job. This is a real long-term process. Our patients are with us an average of about 2 years. It'll probably be longer than that because we haven't been open that long. And while they're massively benefited from this and kind of night and day differences in their day-to-day functioning in their depression, there will be points they have to come back. And making sure that patients know that, helping with keeping in touch with them over time, those are all things that are not normal emergency medicine, but also really meaningful for the right people who are looking for that kind of role.
Hey, listeners, this is Kim, and I just want to acknowledge that you're here for a reason. Maybe you're stuck in a cycle of long shifts, feeling a little burnt out, and wondering if there's any other way to practice medicine, especially on your own terms. We've been there, and that's exactly why we created this free checklist, your step-by-step roadmap to starting a ketamine clinic without those costly mistakes. Grab your copy now at www.ketaminestartup.com/checklist. It's completely free because we want you to succeed, not struggle. And hey, if you're driving or mid-workout, don't sweat it. Just check out the show notes for the link when you're ready. And again, that's www.ketaminestartup.com/checklist. Now let's get back to the episode.
I want to get even more logistical here and ask you about IV placement because this is, at least for me in my practice, I remember learning IVs in med school, practicing on the other students. And I did a little bit in residency, but it was mainly outsourced to the nurses. So did you have that challenge and did you practice IVs? How did you get good at IVs, especially the first 2 years at the pilot site?
I had a very different residency than that. At Kings County, we put in our own IVs, and it was actually part of residency that particularly we had a critical care trauma area, and every roughly 4 shifts would be a CCT shift, critical care trauma shift. And there, as the junior resident, the first 2 years, your job was to get a line, get labs, and get access on every patient who came through the trauma bay, who came through the doors. And so one of the real blessings of Kings County training was that I feel very comfortable with IVs. And we look for docs with a similar orientation where they feel really comfortable with this. The model of care that our practice has, our docs treat a third of the visits end to end. Every patient's first ketamine infusion is with the doctor for the full 90 minutes. We do have nurses, they see the other 2/3 of patients. And even for those other 2/3 of patients, our doctor's still seeing them. So every visit in New York State for IV ketamine requires a physician assessment and a physician interaction. So all of our patients have the doctor talk to them, make sure they're all on the same page, come up with a care plan. And then about 2/3 of the time, the nurse will take over for the IV and the infusion. But for the other third of the time, it's the doc who's just in the room the whole time. And so they really do need to be comfortable with this. And we help train folks if they have a little bit of rust on those skills, but it's not outsourced care in our practice. It's really core to the services that we give. The other big thing we found, and we can talk a little bit more, we're big, our practice is a real big believer in the patient experience, and kind of how ketamine has this effect of altered state of consciousness. And I can talk a lot about kind of how we try to help support that. But one of the things we found really early days was that the patient has to trust you. And it's a real quick breach of trust if you stick somebody 4 times. That makes them anxious. Even the kind of smoothest, most charming person in the world, after that 3rd attempt, the patient's going to have some doubts and have some concerns. And if you have if a patient has some concerns and then goes into an altered state from the doses that we give for depression, there's a much higher likelihood that's a discomfortable process, that there's agitation, that there's fear, there's anxiety, there's a panic attack. And so it's not just a nice thing to do. It's actually part of the experiential component of this, is to make sure that it's gentle, it's smooth, it's seamless, knowing that as we talk about kind of setting or intention setting is what we do here. You can set the most powerful intention in the world psychologically, but how you feel going into the session is going to be its own intention. And really making sure that we've lined all of that up.
Yeah, that's beautiful. I'm really glad you brought up the concept of intention setting as well as the environment, the mindset. So walk us through how it works. So let's say a patient reaches out to you, they call Ember or they, shoot you an email or your staff. Like walk us through the process. What's that look like at your site?
Yeah, so we're big believers that the first conversation should be with the doctor. And so patients who reach out to us schedule a call either on our online tool or with our intake coordinator. That call is scheduled with one of our MDs. And there's a whole half hour our doctors take out of their schedule. We don't charge patients for that. We felt pretty strongly that it didn't make sense to have somebody pay for something where they're getting an assessment about whether that would make sense for them or not. Kind of a policy thing. And in that call, we talk about, hey, tell us about you. Tell us about what you're going through. We have questions to make sure there's kind of medical safety, psychological safety, clinical appropriateness of this. Our practice is really firm. We only treat clinical depression. So we only treat major depressive disorder or bipolar disorder. Patients can have other things too. 2/3 of our patients have depression and anxiety disorders. A third of our patients have PTSD. 14% of our patients have OCD. 7% of our patients have substance use disorder, which is a whole conversation about working with folks who have depression and substance use issues with ketamine, a controlled substance. The point is they have that call. We learn about them. They learn about the practice and what ketamine is, how it works, and how the protocol might look. And then if it sounds like a good option, they kind of proceed forward. And proceeding forward in our case means that they give us permission to talk to their psychiatrist, their therapist. We have to talk to those providers before they start care with us. That's a requirement for us, is that collaboration. And then we run them through what we call a foundation of care. So if they are clinically good fits and they don't have anything that would make us concerned for outpatient ketamine, then all of our clients go through a 4-visit induction series. So 4 treatments within 14 days. And those visits aren't on consecutive days ever. There's kind of a data reason I feel strongly about that from published evidence and also our own data at this point. If those 4 visits cause treatment success, so the academic publications would give about a 75% chance of a patient achieving treatment response for IV ketamine 0.5 mg to 1.0 mg per kg. So that's fixed dose range, 40-minute infusions 4 times in 2 weeks. Should result in 3 out of 4 patients having a meaningful improvement in their depression. So a PHQ-9 score from improved by 50%. So from a 20 to a 10 as an example. Our data, the stuff that we're publishing, shows an 84% treatment response rate. So we're actually seeing better than the published data, which is one of the reasons we're excited to publish. And I don't think that's because we do ketamine differently. I don't think it's anything about our clinical services. I think it's about the care coordination. It's about the intention setting. It's about the making sure our patients have therapists. And actually, we can statistically see differences in patients who go through therapy versus who don't. And then if all of that is successful for the 84% that this works, we then have a very structured long-term care program. And it's about kind of learning for that person how often their symptoms come back. There's kind of a learning phase assessment period where we provide continuous monitoring. We check in with them every couple of weeks to make sure things are still okay. When symptoms return, they come back for a booster. And then eventually we tend to learn a cadence for that booster process. And then they go into maintenance care where, this person comes back every roughly 4 weeks. Let's schedule their boosters for the 4-week mark. Let's get ahead of this as opposed to waiting for it. And that's where the stuff that we're really excited to publish comes from. So as example, on average, our patients come back once every 6 weeks for a single infusion. We see really good durability for this in such a structured process. And it's really variable. 10% of the people we help in the long term come in every 2 weeks. So 1 out of 10 clients are coming back twice a month to maintain this. That's not a choice they're making. That's just for those individuals, their symptoms return more quickly, likely to do with their predisposition for depression, the stressors in their life, etc. And a different 10%, so the other side of the same bell curve, 10% of the folks we work with come back every 4 to 6 months. So they're coming back twice a year, and they're depression-free between visits by definition. That variability is why we feel so strongly about kind of individualized long-term care. But it's one of the things we're really proud of, and that we can actually put enough structure to how to do this that you can give people clarity on how to follow up and how things go over time.
Yeah, so it's really interesting. So instead of like the 6 series that's typically published, twice a week for 3 weeks or 3 times a week for 2 weeks, yours is a little bit different in that it's 4 sessions in a 2-week period, and then kind of after someone finishes those 4 treatment sessions within a 2-week period, then it's almost, figuring out the cadence, whether it's, every 2 weeks or whether it's every, twice a year is what I'm hearing.
Yeah, how nerdy do you want me to get real quick here?
It's super nerdy.
All right. The 4 versus 6 debate is one I love having because it's
Okay.
got a bunch of data for it out at this point. McIntyre, there's some groups in Canada who published a lot of data about 4, I want to say 2020, 2021. There's also an RCT. There's a trial that actually looked at 4 versus 6. It's a small study. It's got like, I think 50 patients total. But what it showed was that the outcomes were the same for those two groups. That if you did 4 as an initiation, you did 6, you didn't see statistical differences. That RCT had some issues, so it's not like the thing to believe in and of itself. But those other publications about doing 4 only and then going into long-term care, there have been a couple of groups now that have put out good papers on 4, and they showed the same total outcomes as doing 6. And so if you believe those cohorts, which we did from the initial data, then it would seem like the 6 is unnecessary for most. The why of that's fascinating. So there's a couple papers on this topic when you look at the 4 side, one of which talks about the trajectory of treatment response. Super nerdy. But basically, when people walk in for visit number 4, 25% of people for whom this is going to work don't feel better. And they take 7 to 10 days to start feeling better. So you actually have to talk to them 2 weeks after their last induction series visit to learn how they did. And that 25% of people will eventually do better in that 7 to 10 day window after the treatment. The reason I think there's so much debate in this field is if you just say, oh, just do 6, well, then you've treated them twice more in that 10 to 14 days where they would have otherwise gotten better on their own from the prior treatments. And you conflate the improvements from visits 5 and 6 as the thing that changed it, as opposed to just realizing that if had you waited, they would have changed anyway. This is, again, one of the things we're publishing. We see that exact same trajectory where 25% of our patients on visit 4 say they don't feel better. We say that's normal. Don't worry about that. We're going to talk in 2 weeks. We're going to check in before then. There's a 1 out of 4 chance you're still going to do better with this. And that's how it pans out, is that the best PHQ-9 is roughly 10 days after visit 4. And so not to make people nervous if they're not feeling better on the 4th visit, that's pretty typical. You just got to give them the confidence to wait it out. And then make sure you're checking in with them. So not just saying goodbye after the in-office visit, but we do phone calls with them. We do nurse check-ins with them to make sure that they're assessed to give it enough time for them to respond.
What do you think is happening in that 10-day period between the 4th infusion and then that 10-day check-in? What's going on from your perspective?
So the way that we describe ketamine's effects for patients, and this answers your question, is that we talk about this 3-part framework. Your audience might be aware, ketamine is literally the single most studied drug for clinical depression in the last 30 years. There are 50% more trials on ketamine than there are sertraline, and there are on Zoloft. So it is difficult to summarize 2,000 papers of academic data. Our attempt to summarize it is that 3-part framework, where we talk about, okay, ketamine does 3 different things all at the same time. The first thing it does is a biologic change. IV ketamine, very specific dose, whatever protocol you're looking at, it leads to a regrowth of neurons in a patient's emotional reward system. You can actually see on fMRI a change in neural connectivity and neural blood flow within days, like hours to days, as a result of exposure to ketamine. Without being too specific, essentially, if you think of depression as the result of stress and trauma over time to the brain, and what stress and trauma do is that they prune neurons in that emotional region. That's the neural circuitry theory of depression. Then ketamine regrows the neurons that had been pruned. Essentially, it's easier for the brain to have a neurogenesis and synaptogenesis in regions where it used to be there. And there's this rapid reset where the emotions go back to feeling appropriate for the situation. So all of that biologic effect. People feel relief. based on initial biologic response of regrowing neurons in those regions. The second aspect of ketamine is the experiential part. So we're big believers that the experiential components of care are not a side effect, but they're actually one of the things that have psychological utility for patients. And studies back that. There's 12 different studies now that have shown differences in the psychological state when the medicine's in your body correlate to treatment outcome. It's not causative, but at least it implies that there's a strong connection there. What patients talk about are things like insights, shifts in their perspective, material that comes up from this, that's so psychologically fruitful content of that session. And then you can do a lot to shape that. So intention setting, ritual setting, music therapy, one-to-one care, de-escalation is necessary. There's a whole bunch there. And then lastly, there's this longer term process where, as a result of an IV exposure to ketamine, for 2 to 3 weeks after the infusion, the brain is measurably more neuroplastic globally, not just in that emotional region. Sam Wilkinson at Yale has published a lot on this. They've got a great study of CBT. There's also mice data showing connectivity changes for a while, and human trials where they show that psychotherapy post ketamine, not during the altered state, but in the weeks after the altered state, is measurably more effective than it would have been had they not had that ketamine. So RCTs of this. So to get to your question, why 7 days after? Well, it's a couple things. One is some people need more exposure to ketamine to have the neurogenesis in that emotional region. It's the longer you've been depressed, the more infusions you need before you respond. If you've only had depression for a week, we can do boosters where you only get one booster and you feel better statistically. But if you're in your long-term care with us and you go a month of being depressed before you come in, the likelihood of a single session being sufficient is really low. You probably go back to doing 4. That's not the time between visits. That's the how long have you had symptoms. And the longer you've had symptoms, the more boosters you need in this kind of series. Yeah, that was a long answer
Yeah.
to your question.
Hey, I'm really glad you are studying the data and the evidence. And like you, I, do my best to stay up to date on the latest ketamine literature. I get like a little Google alert for anything ketamine related. So it sounds like you're doing the same. I'm curious. So you're doing IV ketamine only. You're not doing intramuscular. You're not doing intranasal. You're not doing other routes. So tell us why IV only? And, at least at my office, that's what we do too. But I'm just curious to hear your perspective of why IV only.
It goes back to the system stuff. I'm a big believer in evidence-based medicine. I feel like there have to be a certain threshold of publications before I feel it's a confident thing to do as a first-line treatment. When you look at the route of administration data, so IV versus IM versus intranasal versus oral, at first you have to also be aware there's regulatory issues there. So for your audience who doesn't know this, the FDA put out a warning against compounded ketamine October 24, if I remember correctly, maybe 23. And so as a practitioner, if you're using intranasal racemic ketamine or lozenge ketamine, be aware you're technically practicing against what the FDA says. That's not the clinical aspects of that. That's just the regulatory side. So be ready to answer why you did something that the FDA said don't do. The reason they said that is some of the evidence stuff. So when you look at the studies that have been published on ketamine for depression, 90-something% of them use the IV route of administration. So when people quote 75% effective, they're quoting the IV data specifically. To my knowledge, intramuscular publications, RCTs, trials and stuff, there's a little under a half dozen of them. They're smaller sample sizes, usually like 10 to 20 to 40 patients. There are, I think, 1 or 2 that are in the 50s. And the efficacy for intramuscular appears to be a little bit lower. It's still good. It's like 50%, which is still pretty reasonable treatment success rates for a modality like this. But they're not 75%. We don't have an RCT of that, so no one's going to be able to say with 100% confidence IV is always superior to IM. But what is published would suggest that the IV's got a 25% more likelihood of helping. When you go to intranasal, the data would suggest about a 40% efficacy rate. And when you go to lozenge, the trial data would suggest as low as like 15 to as high as 30% efficacy. Without getting into the FDA stuff, that was one of the reasons why we felt so strongly that, hey, I mean, to be clear, oral ketamine, 30%, that's just as likely as Prozac to work. So it's not that these things are ineffective. It's that when you're talking about giving somebody the best statistical chance of doing well, the IV route would be the strongest contender for that from a data back perspective.
Thanks for sharing that. And to add to that, one of the things I also like about IV is that I can stop it at any time because it's a slow infusion and it's really nice to be able to pause it or stop the infusion if there is any adverse reaction or, anything, any reason, vital sign, abnormality, or, anything serious. I'm always able to stop it. And that's pretty reassuring for me versus
For sure.
one-time intramuscular. So kind of like a safety perspective is one of the things I love about it.
Yeah, I would agree with that entirely. So when you look at the studies on this, the medically significant adverse event rate for ketamine, for IV ketamine, is roughly, depends on the paper, but it's either 1 in 1,000 visits or 1 in 10,000 visits. That sounds really low in terms of bad things only happen 1 in 1,000 times, 1 in 10,000 times. The challenge is if you come to the ER with something, if you had a chance of an MI that was 1 in 1,000, we'd obs you or hospitalize you and take you to the cath lab. Like, it depends on which of the markers are coming back in that range. Our practice has done 36,000 of these infusions. We've seen those bad outcomes. We've made sure that they're monitored, the patient's okay. We haven't had long-term consequences because we've got a doc in the office to manage it. But had we not had a physician present, this is why ketamine is a safe drug, but it is not a perfectly safe drug. Hence the need for observation. And then your point is exactly that. When we have an adverse event, we stop the pump and we can do something. And all of a sudden, with a half-life of 15 minutes, like, you stop the pump, you stabilize them, you're probably okay. But if you can't turn it off, then you got to manage an adverse event with somebody who's altered, who isn't necessarily responsive and able to cooperate in the management of that event. That can go really poorly.
Yeah, thanks for that, Nico. And, as the sun sets on this conversation, I would just want to ask you just a few more questions. So, you've been running and owning and operating and managing and being the systems guru at Ember Health. What is one piece of advice that you would offer to anyone who is looking to open up their own ketamine infusion practice?
One would be hard. There's three that jump to mind. These are kind of the pillars of how we think about it. Uh, when it comes to kind of the evolution of how you can build something like this, one is just listen to your patients. Regular patient feedback. This is all about taking care of people. Those people have thoughts on how they can be helped, and just continually listening. Tiffany, her role right now is the chief experience officer. Like, that's what she does. And we've interviewed, like, phone conversation interviewed close to 20% of our patients at this point. So not just like talking to them clinically, but like they take time with Tiffany on the phone to give feedback and we can help learn. And some of our best improvements have come out of that. Things like reflection areas for patients afterwards, better partnerships with providers, et cetera. The other aspect is really to focus on the team and the people. This is a service-based industry. Like, our existence is about providing clinical care. That is people, doctors, nurses, administrators who provide that care. And so if your team isn't feeling excited, happy, motivated, they're not going to provide great care. And you really have to focus on that team and that management of people. And then the kind of evidence-based medicine operational excellence. So really having a clear idea of how this is going to work, really clear protocols, really clear safety standards, really clear escalation, really clear visit structures, and trying not to kind of wing things, but have an idea of intentionality. Like, have a reason for everything that you do. Be able to articulate the reason of why you do it in that way. Feel comfortable defending that, talking about that to somebody who kind of prods you about it and ask why 4, not 6, et cetera. And feel confident in what you're doing and why you're doing it.
Yeah, thank you. And just couple more fun questions. So, after a long day at the office or, whether it's seeing patients or kind of doing the administrative management aspect, what's your go-to way to kind of relax, chill out, and de-stress?
I've got a couple. So I try to exercise regularly. I was a rower in college, and then physical activity is one of the things that keeps me sane. I live in Brooklyn Heights. We've got the promenade. We've got Brooklyn Ridge Park. I can run on that in the mornings and kind of go into the day feeling better than I might otherwise have, even if it means I wake up at 5:30 to do that. And then I also have a really supportive family. I mean, my wife and I are in this together. That's a really cool thing to be able to do with your partner. It means our boundaries get blurred a bit. We talk shop at dinner, but it also means that I've just got this persistent support process where we're able to kind of tackle anything together. We've got our 2 kids. We get to spend a lot of time with them at home where we get to drop them off at school, pick them up. She picks them up from school, but we get to have dinner together every night. And so being able to spend family time is kind of the balancing act of this, and sit on the porch reading books to the kids and tucking them in at night kind of helps keep it all balanced and sane.
Yeah, and I do want to give a shout out to your wife and my wife, Tiffany, and Kim, because Kim, she's also my partner in our clinic, and I know I could not do this without her. And similar to you, we're talking shop a lot, but at the same time, it's a huge amount of support. So shout out to both of our wives. 'Cause they definitely make us better. So thank you, Tiffany. Thank you, Kim, for being a huge part of our success. And know that we couldn't do it without you both.
For sure.
Another fun question. Let's see here. Just a couple more.
Okay.
Do you have a hidden talent or hobby that most people would be surprised to learn about, Nico?
I don't know if it's a hidden one, but I'm our coder. I do all of our own IT side of things. Not a normal doctor thing, but I had a minor in CS in college. And so a lot of our automations, a lot of our tech stack is me from sitting there. We've upgraded recently. We now have an additional contract coder because there are limits of what a doctor can do. But it was really fun to be able to say, hey, our EHR can't do X, so let's build something that does it. And that has been able to kind of come out in really beautiful ways over the course of our practice.
That's so awesome that you're a coder. Have you used any of the AI tools, whether it's Grok or Claude or Chat GPT, to help a little bit with the coding?
Yeah, I really, really like open evidence. So I don't use AI for coding. I use AI in like open evidence is a great way of synthesizing the updates on ketamine. And OpenAI is a really great way. Open evidence is a really great way of saying, hey, I'm pretty sure my cardiorespiratory monitoring policy is up to date, but have I missed anything in the last 6 months that might affect our policy level kind of stuff? The AI tools are a little bit like Excel to me, like they're really great tools for the thing you're using them for. And so figuring out like what are the things that are made better by having this external brain. Um, the actual vibe coding, so to speak, that isn't something I've tried yet. I've got enough on my plate to try to teach myself that new skill. Although I hear from our contract coder that it's super helpful. I'm trying to limit what I do in the way that I have people now who can support me that don't need me to reinvent the wheel.
Wonderful. Nico, if you could go back in time for a day, where and when would you go and why?
Uh, it's going to sound super.
Or into the future. If you could go back, let's say you were in the DeLorean from Back to the Future. You could go into the past or the future.
Future, I'd probably leave alone in the sense that we've had so many ups and downs with the practice, with life, COVID, all of this stuff that we've always gotten better because of the adversity that we've had to deal with. Like I feel really strongly that we emerge from struggling through these things stronger. And there's a part of me that if I knew what the future looked like, I feel like I'd be less willing to just roll with it when stuff comes up. Um, Past is going to sound sappy, but I'd probably snap back to when my kids were newborns. There's just a real awesome feeling of having a little munchkin on your chest. And mine are 6 and 4 now. They're still awesome. And I won't have that again. Or I don't think I will have that again. And so there are strong memories, but if I could re-experience it, that'd be pretty cool.
Awesome. And I don't know if you're into reading, but what's one book or two books that that you would give someone, or you're like, hey, you'd highly recommend this book?
I used to answer Stranger in a Strange Land when asked that question. Robert Heinlein sci-fi book from the 80s, 70s.
Mm-hmm. Yeah, old school.
It's very old school. And when I was in college, it was one of my favorite books. As I get older, it's got some quirks to it that I'm not sure I'd recommend as a default for folks. Nevertheless, some of the concepts in there about kind of unconditional love, grokking is a term that comes from that book, where it's like to know something so well it's become a part of yourself and to kind of blur the boundaries between oneself and the thing that you grok. That was in my wedding vows with my wife. So despite some of its oddities in modern time, still a really powerful read for folks who kind of want to have a different way of thinking.
Yeah, thanks for sharing that. I have not read that book personally, but I know Kim, my wife, has, and she enjoyed it. So I'm definitely going to check it out. And just two more questions as we wrap up. The second to the last is there anything else important about the ketamine space or, just in this field or just life in general that we haven't talked about that you want to share? And then the last question will be, where can people learn more about you, connect with you?
The things that feel really kind of foundational for people doing this work is to really just have strong moral principles and strong kind of frameworks for how you do things. We talk at Ember that there's this kind of, we have the three things that ketamine does for a person, the kind of explanatory power of rapid reset, psychological content, and then adaptive learning. But there's also some pillars that our practice feels very strong about. Kind of evidence-based medicine is like the thing that you must focus on and contribute to the evidence, but also follow that. Patient-centered experiences, like make sure that you're doing things in the service of the person in front of you. One-to-one care, I feel really strongly about. So is a guiding principle for other practices to really have good reasons why you are considering the staffing ratios that you're talking about. And then partner oriented. Again, we don't treat folks who don't have that larger mental health care team. And so feel really strongly that frameworks like that, they don't necessarily need to be the same framework we use. But whatever framework you're doing, have the intentionality behind it, have the kind of understanding of why you've chosen that, and be able to feel that you've made those decisions for the right reasons.
And then where can people learn more about you, connect with you when they're interested?
Our website's probably the easiest way to reach us. So emberhealth.co. My email is pretty easy. It's my name, NICO at emberhealth.co. So people should always feel free to reach out. Patients get to us on the site and they can actually book that time with their doctors directly. And then other physicians, other clinicians, anybody else who's interested should always feel free to reach out to me. And if you forget my email, the website has it. You can always connect that way as well.
All right. Well, thank you so much for your time, Nico. It's been a pleasure talking with you, and I've learned so much. I want to acknowledge you because, the way you articulate how you run the practice and kind of these mental conceptual frameworks, I think it's really powerful. And I don't know, just having a clear articulation of it has been incredibly useful. So thank you for the work. Thank you for applying your systems thinking to this. You are definitely contributing to our field, and it's really an honor to have, be friends with you, be connected with you, and interview today on this podcast.
I really appreciate that. It means a lot. And yeah, I can't take credit for all of that. That's where Tiffany comes back because we've given them credit, but to give her even more credit for stuff like this, she is the brains behind a lot of the structure and stuff. But really appreciate the kind words. It means a lot. And it was my absolute pleasure being here today.
Thanks for tuning in to another episode of the Ketamine Startup Podcast. If you found this episode valuable, we'd really appreciate it if you could leave us a review on Apple Podcast or Spotify. It helps other entrepreneurial medical professionals discover the show and grow this community. For show notes, resources, and links mentioned in today's episode, visit our website at ketaminestartup.com/podcast. Thanks for listening, and we'll see you in the next episode.